Infection, echinococcosis, hydatid disease. Etiology, caused by Echinococcus granulosus, a tapeworm. The definitive host is the domestic dog and occasionally foxes. The adult worm lives in the intestine of dogs. The worm is 3 to 6 millimeters in length and is formed of 4 segments, and the head has 4 suckers. The microscopic picture of the worm. The host. The definitive host is dogs and other canidae, and the intermediate host is the sheep, goats, and swine. Infection of the intermediate host on ingestion of eggs of the definitive host, and infection of the definitive host on ingestion of cysts from the intermediate host. The life cycle. The life cycle is well described here. You can study it. Its ova are set free from the distal segment and evacuated with the stools of the host. The intermediate host is a grazing animal, usually sheep and cattle, but occasionally man. Echinococcus granulosus ovum. Man accidentally replaces the sheep by ingesting ova from the dog's feces. Human infection usually occurs during childhood. The digested ova hatch in the upper gastrointestinal tract. The hatched parasite reaches the liver through the portal vein. The parasite metastasizes from the liver mostly to the lung or less commonly to other sites. The settled parasites in the liver, lung, or other sites develops into hydatid cysts. The hydatid cysts. Hydatid cyst in X-ray. Hydatid cyst in X-ray. The definitive host catches the disease by eating infested animal organs. The disease is common in sheep-raising countries like Australia. The definitive host catches the disease by eating infested animal organs. The disease is common in sheep-raising countries like Australia. Pathology. The hydatid cyst in the intermediate host has 3 layers: the adventitia, the laminated membrane, and the germinal layer. The drawing of the layers of the parasite. The adventitia. The adventitia is the outermost layer of the formed of compressed host tissue and dense scar tissue. It is formed as a reaction to physical and mechanical presence of the parasite. The laminated membrane. It is inner to the adventitia. A plane of cleavage is present between it and the adventitia. It is a white gelatinous acellular layer. It permits transport of essential nutrients to the cyst. Also, it prevents transport of harmful substances like antibodies to the parasite. Standard surgical excision depends on detaching the laminated membrane from the adventitia. The laminated membrane. The germinal layer. It is the infective part of the cyst. Brood capsules bud out from it. Brood capsules are small vesicles containing the protoscolices. Protoscolices are microscopically recognizable as worm heads. Pathology of the cyst fluid. The cyst contains fluid. It is crystal clear in viable cysts, turbid or bile stained in degenerating cysts, and has toothpaste-like consistency in dead cysts. In viable cysts, it contains the hydatid sand. The hydatid sand consists of brood capsules, protoscolices, and degenerated hooklets from the dead protoscolices. The germinal epithelium and the cyst fluid containing the hydatid sand are infected. Spillage during surgery leads to dissemination. Natural history. The cyst may undergo growth, rupture, infection and suppuration, death and calcification in 25%. Growth. It may remain viable for as long as 40 years. It may attain a huge size. It may cause local swelling and pressure manifestations. Rupture. It may be spontaneous, traumatic, or iatrogenic. Rupture may lead to hydatid anaphylaxis or secondary echinococcosis. Clinical picture. The site. The liver in 50%, the lung in 30%, and the other organs 20%. Symptoms may present with systemic allergy, local pressure effects. Symptoms depend on its location. Details are present in the specific sections. Systemic allergy, local pressure effects, investigations. Eosinophilia in 40%, serological tests, Casoni test, hemagglutination and complement fixation tests. The Casoni test. It is accurate in 80 to 90% of cases. Intradermal injection of 0.5 ml of fresh fluid from sheep's hydatid. Urticarial wheel develops within about 20 minutes in positive cases. It remains positive even after cure. Hemagglutination and complement fixation tests. They are accurate and useful. Their advantage is that they become negative after disease eradication. They avoid the disadvantages of the Casoni test. Treatment, surgical or medical. The surgical treatment. The treatment of choice. Cyst removal at the plane of cleavage between the adventitia and the laminated membrane. Precautions to avoid spillage of the cyst contents. Spillage of the contents may cause severe allergic reaction and also causes dissemination and recurrence. Medical therapy indications. Recurrent disease, disseminated disease, surgically inaccessible cysts, unfit patients for surgical interference. Medical therapy, mebendazole or albendazole. Albendazole 10 milligram per kilogram per day in 2 divided doses for 4 weeks. Stop the drug for 2 weeks. Blood count, liver function tests, and ultrasonography before another cycle of treatment. No more than 8 cycles of treatment. The mortality rate, untreated 15%, surgically treated 4%. Good luck and best which